Hi, I'm Dr. Jeff Clement. Welcome to the third part of our module on healthcare payment systems and reimbursement structures. In this part of the module, we'll be discussing one particular plan in some detail and look at the policy trade-offs that are associated with it, specifically focusing on Medicare Advantage. So Medicare Advantage or Medicare Part C versus Medicare Fee-for-Service. What is it? Bottom line. So the idea here is that there are private companies that you can choose to get healthcare through instead of going through your standard, just bog standard, as the Brits would say, Medicare Fee-for-Service plan. All right. And these plans, they are advertised very heavily. We're depending on when you're watching this, this class will normally run in the summer. So you're probably not seeing too many ads for Medicare Advantage coverage right now because the enrollment time is not here yet. Starting in September, you might start to see a lot more ads. And this is big business. You see big celebrities. I pulled this one, William Shatner. Hi, William Shatner here. I'm here to talk to you about the Medicare coverage. And these ads, look, they look really official. Look, there's an American flag, the Medicare coverage helpline. Like, call the helpline, call the hotline. There's all these different ones, and they have very official sounding names. Down there in the bottom of that ad, you can see it's not an official Medicare card, but man, it sure looks like it. That was deliberate, right? You wouldn't want to miss out on your benefits. You wouldn't want to miss out on, have you signed up for your Part C benefits? You don't want to miss out on those. If you don't sign up, you're in big trouble. Like, okay, well, if you don't sign up for Part C benefits, you get your Part A and Part B benefits, which provide basically the same benefits. So it's like, all right. So the idea here is that you can you still pay your Medicare Part A and B premiums if you have them, depending on your income level and other qualifications. Medicare is very complicated, right? And instead of getting your care through your standard Medicare fee-for-service, and instead of you roll into HCMC and you get some care, instead of the MAC, the Medicare Administration. Blanking on the third, the contractor that would send the money to HCMC after you get care that's covered by Medicare. You might have United Healthcare send HCMC that money under your Medicare Advantage plan or Medicare Part C plan. And so this is big. 54% of beneficiaries are now enrolled in Medicare Advantage. So what does this do? This shifts power from CMS as the basically the largest single insurer in the country to all of these individual insurance companies. So what's the best argument that you can make for this? Like, it's a purely capitalistic argument that the private market can solve this problem. And I'm not saying I necessarily believe this. I'm saying, what is the argument that you could put together? Not a straw man. Like, what is the best argument? Hey, that the private market can solve this problem better than the government can, right? And United Healthcare is huge, and they are able to have specific plans in specific states. They're able to use their huge negotiating power to negotiate a better deal for Medicare than the government could negotiate itself, right? Okay, so maybe that's true. So by 2030, we expect that about 70% of folks will, be on a Medicare Advantage plan instead of using Medicare Part A and Part B. A lot of the Medicare Advantage plans also include Part D, that's the drug coverage. And they'll also have extra benefits like dental and other, there's this like telehealth thing you do. And we have this like wellness thing. We'll send you a Fitbit and like all this other stuff. Why are they doing that? Because they want you to sign up, because they're paid on a capitated basis. So United Healthcare, if you sign up for one of their UHC1 Medicare Advantage plans, they have like the AARP Medicare Advantage plan here in Minnesota. They have a couple different plans, right? Why do they want you to sign up? because then they get your capitated payment, right? The government, you still pay your Medicare Part A and Part B premiums to CMS just like you would if you have to pay those. And then the government pays to United Healthcare the capitated payment per month per member. And if you stay healthy, then United Healthcare wins, right? So that's kind of what they, that's the game. So how does it work? One concern was that it would actually like really, you'd see that these health plans would force Medicare Advantage patients into really narrow networks, basically the HMO model, right? That they're gonna be forcing these narrow plans, and it's gonna suck, and it's gonna really reduce their choice and access to care. Fortunately, that actually hasn't really played out. This paper was published in 2019. Yeah, 2019. A bunch of 2019s. It's also just kind of a coincidence. A bunch of these come from Health Affairs. Health Affairs is probably the best journal that's covering a lot of these. It's a really rigorous journal, and some of my friends, in this case, Yevgeny, he's a friend like that I've only met digitally, but cool dude. So anyway, a bunch of health affairs papers. So this is one of his papers. And basically what they found is actually the opposite, that like most plans on average have tended to get more broad over time. And the number of plans that they argue are really narrow in scope have actually gotten fewer over time. And then a lot of the ones that are really narrow tend to be in like highly concentrated urban areas where access is maybe not as much of a problem, but you have like really established health systems that have a lot of existing market power. And so it's not a specific Medicare Advantage problem, basically. And this kind of makes sense when you think about it. Again, what are the incentives? Well, people have choice. They could they could just keep their regular Medicare and go anywhere that accepts Medicare, or they could sign up for Medicare Advantage. And if I sign up for a Medicare Advantage plan and it sucks and it forces me to go to one clinic that I don't really want to go to, well, I'm not going to sign up for that. And I might sign up for it this year and I'm going to be like, well, I'm not doing that again. Right. So the incentives are for if these insurance companies want the plans to be attractive to people, then they're going to make the plans attractive, and they're going to have good benefits, and they're going to have good networks. So this concern actually didn't turn out to be as much of a problem. So okay, I want to make sure I like chalk up some wins, and I'm not always the doomsdayer, right? Looking at outcomes, overall, like outcomes, again, the concern, what's the concern was that because it's capitated, that outcomes are going to tank and patients aren't going to be able to get the care they need. So actually the flip side was true in this study, again, published 2022 in JAMA, so good journal. What they found was that that enrollment in Medicare Advantage was associated with modestly lower rates of 30-day mortality in 2009 after a heart attack or MI. Not all heart attacks are MIs. But by 2018, that there was basically no statistically significant difference. This paper doesn't disentangle why that might be. I think, sort of top line, it's like, hey, the initial concern is that, Medicare Advantage patients are going to get much worse care and not, have the outcomes that we desire, compared to regular Medicare fee-for-service. I think, this is maybe not the best setting for it. It's kind of extreme, and a lot of times like they maybe don't even know what coverage you have when you call 911 and you get rushed into the cath lab. So I don't know that this is the best condition to look at that. The better rates for Medicare Advantage in 2009 compared to fee for service, that, there's a couple different explanations. One is that the companies were, especially early on when they sort of had their pick of who to, get on your Medicare Advantage plan, they were targeting the healthiest folks. Like, so where do you go? You go to really active, you target really active, older communities, independent living centers, areas where people tend to be really healthy, like Palm Springs, California, where there's like a lot of older people, but they're in good health and they do lots of outdoorsy stuff, right? And you don't target, like urban areas where people are maybe on average a little less healthy. I don't know, right? But then as they, at some point you cap out your market on the healthy older people, and you have to, if you want to keep growing, you have to expand into less healthy older people. So maybe that explains this. I don't think we totally know. Overall, there's definitely some argument to be made that, Medicare Advantage does not provide the cost savings that we think it does, and ultimately is a transfer from the taxpayer to insurance companies. And this is sort of what one of the other readings for this week shows, that you've got, and in particular, why is that? So the key mechanism here is that the risk adjustment is supposed to account for who's healthier and who's sicker. What the plans very consistently have done is they've upcoded patients to make them look sicker than they really are, to make sure that they capture every dollar that they can. No surprise there. So this is where you're going to need to be mindful of what plan your patients have. And then from like a policy perspective, we need to really get a handle on the risk adjustment. But again, it's a tension, right? If you make it too hard and you make it so that nobody can make any money, that reimbursement is too low, well, then the plans just don't exist anymore, which can be a problem. So it's there's no easy solution, and it's very much in tension. And, so then this brings us to like, why is payment reform? Why is this so hard to get better? Like, one, fee for service is deeply embedded. Like, we have a whole module on RVUs. Why? Because that's how it's been done. That's the dominant model. That's how, even internally, whether or not, how many healthcare systems use RVUs to measure productivity for PAs, whether or not those patients are being paid, if they're not Medicare patients, right? You might look at the RVUs for this patient, even though they're commercially insured. So it's like built into everything we're doing. Okay. All of these systems, there's winners and losers. So if, every payment reform creates winners, it could be the primary care, and losers with the proceduralists, right? If you make things easier for, folks who are, and you push more folks to primary care, that might pull people away from specialists, right? Or vice versa, right? So think about like, sounds great to let people go see specialists without accessing primary care, but that might mean that there are a lot of small primary care practices that suddenly lost all those referral visits, and that represents lost revenue, right? And there you go. Like, organized medicine is effective at blocking reforms if they threaten revenue, right? And this is, not just at this point, it's the large systems, right? Measurement problems. So if we want to, what are we trying to get to? Let's, again, like think about the Grossman health economics model. What we're actually caring about at the end of the day is utility of your life. That's really what he focused on. And he sort of worked backwards into healthcare from that. So it was like, because everybody's sort of like, and this was in the 70s. So everybody's like super focused on like healthcare. It's like, and he was like, well, actually, people don't actually care about healthcare. They actually care about health. They actually don't want healthcare. They invest in healthcare to obtain health. And actually, they don't want health either. What they really want is utility from their life, enjoyment in their life. And ideally, you don't think about your health, right? You just go about your day and you do things that you love and you have a good time and you spend time making the world a better place with the people that you love, and you don't think about your health, right? So this requires like, hey, how do you measure that? That's really hard, right? And how do we measure that, okay, this person is sicker than that person? And, there's lots of, the Elix-Hauser comorbidity index and all these different metrics, and they're all imperfect, right? a lot of them are better than nothing, but they are not perfect and they're gameable, right? And so, yeah, if you're an insurance company and you are charged, like we adopt this, capitation model, something like that, and you're charged with taking care of the population in rural Alabama. That's a hard job, right? Like there are structural, socioeconomic, embedded health equity problems. That's the other thing that Grossman pointed out is that healthcare is only one input into health, right? And so you're fighting substantial headwinds if you are an insurance company providing, for the paying for the healthcare of folks in rural Alabama compared with Jackson Hole, Wyoming, right, where it's the average income or average net worth is in the tens of millions, right? I mean, those are just different populations, and you should be compensated differently accordingly. But how do we really measure and distinguish that real risk, right? And then finally, the political economy. Getting anything done and changed these days is tough, for sure. So, reform, it requires trust in the new systems. The passing the Affordable Care Act cost the Democrats the House and the Senate, quite frankly, and people, lambasted, the Democratic leadership, and they knew what they were doing. They knew that that was going to happen, and I give them credit for that. Like that was, I happened to have a good friend who was a good friend of John Boehner, who was the Speaker of the House in the sort of immediate aftermath of that. And he so sort of had some second hearsay, but I believed it. Insight into some of the discussions that were happening on the Hill. And I lived in D.C. at the time. I had some friends who were sort of Democratic insiders as well as Republican insiders. And there was not trust in that new system, and they went ahead with it. But and then even now, people still don't trust and understand it. So like getting moving to something else is gonna be tough, and that's why change is difficult. So that's where we'll leave this this module. I got a lot of, we've talked about a lot of content. A lot of it you've probably heard before, but hopefully this sort of puts some context and structure around some of these different things, so that you can sort of understand how they affect what you do day to day. I got a lot of questions. I know we know what the problems are. We don't have a ton of answers. So again, best recommendation is, build a sustainable healthcare organization around you, influence what you can influence, understand how these forces are affecting what you're doing, and then advocate for change where you can. So we'll leave it there, and I'll talk to you next week.